So in this particular podcast, we're going to talk about the question of high-risk disease. High-risk disease occupied our discussions for a long time, and we had a great chat about it. And I brought along here an excellent panel and also a discussant, who is Axel Merseburger from Hanover, who's going to tell us what he took away from the meeting about defining treatment options for high-risk disease patients.
Well, John,
Axel.
Thanks a lot for the introduction. First of all, to start off, my disclosures. So, when looking at high-risk disease, castration-resistant prostate cancer in a metastatic setting, we have to define this disease. And we've discussed a lot on the definition of those high-risk disease men and decided that visceral metastasis is one point of high-risk disease. And this is also increasing due to the novel substances, not only in clinical trials, but nowadays approved for the treatment of metastatic CRPC. Additionally, the patients with poor clinical conditions are the ones who will be queued in the group of high-risk disease patients. Aside that, we had talked about markers and the role of markers in decision-making and also in prognosis and prediction of the disease progression. And so far, we have some prognostic markers like C-reactive protein, LDH, or Gleason grade, a high Gleason grade, and also the Psa doubling time as some discussed markers. However, so far, no predictive, validated, or novel, or even one of those old markers is approved in clinical practice. Aside, very astonishing, the different heterogeneous discussion among the economic situation within Europe, not only for urologists, but also for treating oncologists or radiation oncologists. And let me present you one example. For example, when you just have one sequence to choose because of economic situation, what do you do when you start with carboxytaxel and have a side effect profile not allowing to continue the treatment? You're not able to switch over to abiraterone, or when it's approved MDV 3100. So I think this is something what has to be further discussed among the politicians, the societies, and also the patient groups and the doctors. Aside, in those high-risk patients, I think it is of crucial importance to maintain health-related quality of life, aside with a prolongation of overall survival. And those are the points we were summarizing and we are about to discuss within this excellent panel. Thank you very much.
Thank you very much, Axel. I think we'll use what you've just said as a sort of a framework for a further discussion. The one thing I'm not going to talk about or not invite comments about are the economics considerations. I think all of us would agree that economics is not necessarily a scientific subject, and it's perhaps a little bit outside our remit. However, we all also know that it is extremely important in reimbursement and people deciding exactly what drugs we can and cannot use. Okay, so our first panelist is going to be Maria De Santos from Vienna. Maria, you heard Axel talk a little bit about the question of the definition of high-risk disease. Can you give us your views as to what exactly that means to you?
Well, yes, thank you for the question. I think high-risk patients are those who are symptomatic, those who are in pain, those who are fatigued, and those who have a decreased performance status already because of the progression of their disease. But there are also other parameters like high volume disease, for example, liver metastasis or visceral metastasis, also lung metastasis, would, for me at least, be a sign of high-risk disease. Further on, I think that we should have a look at Psa doubling time. Patients with a short Psa doubling time are high-risk patients. And in addition, I think the time on LHRH before the patient becomes castration-resistant is important. If this time is very short, this, I think, is also a high-risk patient.
So one of the things that we mentioned was the question of visceral metastases. You don't usually associate, for example, liver metastases with prostate cancer, but I think you made the point yesterday that increasingly you're seeing this in your practice. How often do you see liver metastases or visceral metastases in general in your practice?
Well, this number has been increasing recently because patients live longer. And about 20 to 30% of patients do have visceral metastases nowadays. Yeah, not only bone metastases.
Yeah, good. Okay, so it is becoming an increasing problem. Yeah. Thank you very much, Maria. So now we have Joan Carles. Joan is, of course, from Barcelona and is going to tell us a little bit about markers. Can markers help us in this definition, if you like, of high-risk disease? Can they help us to follow up these patients?
Well, in my opinion, I think that those markers may help us, but we have to define which markers are really important in this subset of patients, because as Maria said and Axel said, we are in our daily practice we see more patients with those characteristics. So I think that it's very important to define in the next trial which patients and which markers has to be considered for treatment, because I think that those patients has only one shot treatment, so it's very important to move from the prognostic factor to predictive factor for all our treatment that we have now available for our patients.
So one of the things that we were including in our, if you like, definition was with the question of lytic bone lesions. And Maria mentioned the value of alkaline phosphatase, and I think Joachim Belmont, in one of his points of discussion, mentioned that it is actually maybe a prognostic indicator in these patients. What do you think about alkaline phosphatase?
I think that it's a good marker. I don't really agree that it's only for those patients who has a high risk, because in the Alkaline trial, the normalization of the phosphatase is a predictive factor. So, and in this subset, in this study, not all patients has a high risk prognosis.
Okay, thank you very much, Joan. We'll move on next to Giuseppe Procopio from Milan. And yes. Welcome, Giuseppe. But one of the things that was one of the points that was made yesterday during the discussion was the question as to important issues in high-risk disease at this stage of the disease. And one of them was improving health-related quality of life. Where do you stand on that?
Yes, I think quality of life is certainly one of the most important endpoints of medical therapy for castration-resistant prostate cancer, specifically for the population having a high-risk disease. Because in this subgroup of patients, sometimes there are comorbidities, and the patient received concomitant medications. Additionally, this population presents some symptoms related to their disease, such as fatigue, pain, and the role of the physician should be to control, to improve the quality of life, and it is necessary to obtain a better quality of life, but between a control of the symptoms. And it is not so easy using drugs active in terms of disease control and also active in terms of quality of life. I think also currently are available some agents, chemotherapy and abiraterone. Some randomized study demonstrated an improvement in terms of quality of life in an overall population having castration-resistant prostate cancer. No data in the subgroups with a high risk, but the data in randomized phase 3 study suggests the possible role and the certain role of abiraterone in terms of quality of life. Then the patient currently had a better quality of life and also a better overall survival. And it is a very good point to consider.
Okay. Have any of the trials addressed the issue of quality of life specifically in any stage of the disease? We're talking about high-risk disease here, but quality of life, of course, spreads out throughout the entire disease. Any particular trial that has shown one drug or other to be superior to other ones?
Yeah, certainly. With chemotherapy, cabazitaxel demonstrated a benefit also in terms of quality of life, but in a population refractory to a docetaxel treatment. And the data of abiraterone are now available. And perhaps also in a patient having early disease, then before chemotherapy, could be possible to improve overall survival. And we hope also quality of life. But in the next week, will be presented these results.
Thank you very much, Giuseppe. Now we'll turn to Sergio Barroso from Evra in Portugal. And Sergio, of course, the point was made again that quality of life is very important, but naturally survival to the patient is equally important. But it's been said that maybe in high-risk disease, the expected survival is relatively short. Now, there's been an argument about this, as you know. Some people feel 1 year, others feel maybe 2 years. What's your view in this particular group of patients?
Well, I think survival is the most important efficacy endpoint, and it should be, in general, our primary goal. But we know that the treatments that we have now, and we have seen that before, we have some treatments with an important and significantly increment in survival, but this increment is obtained at the expenses of some toxicities. Some of these toxicities can have a negative impact in quality of life of this patient. So I think quality of life is also a very important point in this group of patients, because we are in a palliative setting, and virtually all of these patients are incurable. So we have to tailor our treatments. We have to adapt these treatments to every patient that we have. And now we have to adapt to the financial constraints that we have in our countries. So we have to mix all these parameters, so to have a good choice for each patient that we have in front of us.
And are you convinced by the survival figures? Do you think that they're helpful? Do you think that they're different, one drug from another, particularly in high-risk disease?
Well, the data we have, it's not so clear in that point. We have some different treatments. Some of them we have by now, we have available, but in the near future we have some more treatments, and all of them with increasing survival. So I think these are very important options for our patients.
Thank you very much. I'd like to thank the discussants and the panel very much indeed, and I hope that that's left you with the message or a summary of what we were discussing over the past few days in relation to high-risk disease. As you can see, there are different views and different ideas on this topic, and I hope that you've enjoyed this particular cast. Thank you.